All right, guys, I'm going to start off with our endocrine and hematological emergencies. I'm going to break this up, like I said earlier in our group chat, into two segments. We're going to do the hematological disorders, basically blood disorders first. All right, yeah. In hematology, some of the things that you need to know or at least pay attention to as far as your EMS portion is concerned. One is going to be your sickle cell crisis, and the other is clotting disorder. We will get into that after we have some good A&P review. One thing you do need to know in these emergencies, they are very rare. It's very rare that you're going to find people that have these type of hematological disorders or emergencies. They're very rare, and really, there's nothing you can do for these patients in a pre-hospital setting. More likely they're going to go to the ER and have something done and receive some sort of care from there. So really it's just kind of recognizing and finding out if they do have the disorder and then trying to figure out what's the most appropriate place to take them. All right. 4 H's. Hematology is going to be the study of blood and basically how it's involved in overall homeostasis. That's going to be your hematology. Hematological disorders refer to any disorder of the blood. That's kind of like the blanket statement for that. Hemolytic or hemolysis refers to any disease process or how blood cells are broken down. Hemostatic disorders have to do with bleeding and clotting abnormalities. So hold on to your hats. Here we go. All right, let's review the blood. 55% is plasma. Inside the plasma, you can have water, ions, proteins, nutrients, waste, gases. 1% makes up the white blood cells and the platelets. We did talk about that in immunology. And the other 44% is red blood cells. So the plasma, it is a transport medium. It is every bit of just that. It is a way to get things in and around our body. It is basically the highway for delivering red blood cells to deliver the oxygen, to get anything in around. If you've got, a disease or an infection somewhere, get the white blood cells there. If you've got a cut or a clot, something that needs to be clotted, good way to get the platelets there. It's pretty much how everything gets transported in and around our body. That's what our plasma is for. Red blood cells, also known as erythrocytes. Its sole purpose is to carry oxygen from the lungs to all the cells and tissues, and then take the waste product, CO2, back to the lungs. And it's like we talked in respiratory emergencies over and over and over again. So the red blood cell is kind of unique. It is a cell, but it has no organelles, meaning no nucleus, no mitochondria, nothing. It does not need to make its own energy. It doesn't have to do any of that. It is just literally just a cell that has hemoglobin on the outside of it, the protein hemoglobin banded together on the outside of it, which oxygen adheres to, and its sole purpose in life is just to go ahead and carry oxygen and CO2, just circle around. Its shape, it's called biconcave. What that means is you look over in here, it's like an inner tube almost. It's basically got a rough exterior bumper on the outside, and it's basically kind of concaved in. That is so it can go through and travel through blood vessels with ease. It's literally like just sending like a little bumper, like pretty much putting down not a bumper, but an inner tube down the river. If it hits something, it'll bounce off and just kind of roll. If you think about an inner tube floating down a river, it's basically so it can move and go with the flow wherever the plasma is going to push it. And the interesting thing that you do need to know is right down here. They only live for 120 days, about 6 months. We will talk about how they're creative, but also know that when they're done, there's something called apoptosis, and I believe it's in here. But apoptosis means that it just basically the cell itself, it just finally just gives up. It can only take so much abuse and being bumped and pushed around for about 6 months till it finally just ruptures. It just fails. It just pops open and it's done. And we'll talk about how it gets recollected and recycled to make new ones. So let's talk a little bit about the hemoglobin. If you look, if you were to pull kind of that cellular structure up, I know that's a cell, but if you pull the protein structure up, sorry, not cellular structure, but the protein structure up, that's what it's supposed to look like. It's kind of like 4 little heme groups chained together that form that protein that's on the outside of there. So it's on the outside of a cell, and it's literally, that cell is covered with this hemoglobin. And the affinity for oxygen, it picks it up so quickly and holds on to it. And then when we talked about, remember, in respiratory emergencies, partial pressure is what moves it. It'll basically go ahead and move to from a higher concentration to a lower concentration. They talk about how many they've got. They've got several hundred million hemoglobin molecules that help transport. The oxygen pretty much binds to it, and it goes in. Remember, oxygen is not a cell, it's an element. So it is the most minute particle that it can be. So even though you have a cell, you're actually looking to get the element of oxygen, and it's bonded together to form O2. It's 2 oxygen atoms bonded together, and that's why it's called O2, oxygen 2. Next thing we're talking about is going to be the platelets. Now, platelets, they should be easy. This should be like, they help form clots. Platelets are also known as thrombocytes, but it's a little more complicated. So hold on to your hats. This is going to get in and above your head. I'm not really going to hold you guys pretty much accountable for most of this, but I'll tell you what I will hold you accountable for. So here we go. Clotting and making a clot is not simple at all. Believe it or not. It's not, you get a cut, oh, we clot, and we're done. It's some platelets, and we just kind of throw them together, and then boom, voila, we're finished. That's not it at all. You have inside your body, in the plasma, clotting factors. And these factors are simply just proteins. That's all they are. But they decided to give them a fancy name and call them factors. So inside the plasma, you have these clotting factors. This is the 13 of them. I put the slide in. I'm sorry it's a little fuzzy, but do not memorize these. Do not try to memorize all these at all. But in there, there's a pathway. There's actually 2 pathways. And I'm going to put this all together. Just give me a second. The intrinsic pathway is if you have a blood vessel or something of that nature on the inside of the blood vessel, and you wind up having a leak or rupture. That's called the intrinsic pathway. The intrinsic pathway, how I remember it, is inside intrinsic. The other side is from outside the blood vessel. You can have injury that is going to require clotting and probably some damaged blood vessels as well, more like maybe capillaries, and that's called the extrinsic pathway. I remember intrinsic because it's on the outside. That's how I remember it. But you'll notice these 2 pathways, they'll come together right about here. This right here is called the common pathway. So you have the intrinsic or the extrinsic. Doesn't matter how the bleed occurs. These are the steps that they're going to take to get to a common point. This is called the common pathway. That's really what I want you to take home from this, is the common pathway. 2 things on this I do want you to pay attention to. Prothrombin. What happens is, let me back up a little bit. What happens is these factors get activated. So somehow you either have damaged tissue, they'll send out a hormone or a release for that, or the blood vessel wall itself will rupture, and it will send out a protein or hormone for that. With that being said, that's what activates it. So, one gets activated. Now, it would be helpful if they started like 1 through maybe, whatever, 6 or whatever, and then maybe 7 or 8, and then they all come together and they finish out with a 13. That is not how this happens. The intrinsic pathway starts with 12, and then it jumps to 11, then 9, and then it goes to 8, and then back to 10. And then you have 7 over here for the extrinsic pathway. It doesn't fall in order, and it's not helpful in the flow of things at all. So again, I don't have this memorized at all, but the things that I do want you to pay attention to is the fact that when they're activated, they convert over, and they activate something else and convert over, activate something else and convert over. So, in the common pathway, either way, whether it's inside or outside of the blood vessel, they come together in a common pathway. Prothrombin kicks over to thrombin. When that's prothrombin's activated, that's what's going to activate the platelets. Also, special note, fibrinogen, when fibrinogen gets activated, it turns into fibrin. We'll talk about why that's important here in just a minute. Those are the only things I want you to kind of just pay attention to and keep in the back of your head of what's going on. All right, so what you do need to know. So if you have a blood vessel injury, regardless, extrinsic or intrinsic, doesn't matter. If you have a blood vessel injury, 3 things happen. The neurosystem will actually cause the blood vessel in and around that area to constrict. It's kind of like having a busted pipe. When you have a busted pipe, what you're looking for is some way to stop it or slow it down, because if it's big enough, you actually have a rupture, and therefore you'll be losing blood. The whole idea is to keep the blood inside the blood vessels. Blood does no good outside the blood vessels. Any other space, it does not work, and it's not going to do any good. So, but your body knows that you're gonna leak. You're gonna have you're gonna spring a leak. You're basically gonna have some sort of disruption in the blood flow. So what happens is the neurosystem actually will take it and constrict down. It'll constrict down the blood vessel and try to make it so minimum blood flow goes by. But it still needs some to go by because it's like a flowing river. You've got platelets and other clotting factors that need to be activated in and around that area. So it needs some still to pass by because you need it to come by. If you dam it up before you get to the actual bust, the busted pipe will never get fixed. So unfortunately, it'll constrict, but it won't stop flow because it still needs everything to flow by there and pick out in the bloodstream what it needs. So you're going to have some leaking. It's basically you're going to lose some blood a little bit, but it's all in an effort to go ahead and fix the leak itself. Then you have something called platelet aggregation. The platelets get activated. Remember the prothrombin, the thrombin? It gets activated. That's going to activate the platelets. I'll show you what that means in a minute. And then you have the coagulation cascade or the clotting cascade. It starts. And remember, it's a cascade. It's the reason why they call it a cascade was when you look at it, it starts and it just cascades down, and one affects the other. One has to affect the other, and we just keep cascading. That's why it's called a cascade. The whole idea is to call it a stable hemostatic plug. That's what a clot's called. They literally call it a plug. They're looking to plug the hole. So some things happen with platelets. So platelets start off nice round little cells. They're just floating through. They're round. Same thing with the red blood cells. They want them nice shape, spherical shape, where they can go through and pass through blood vessels with ease. The rounder, the better. Platelets get activated by fibrinogen. Prothrombin turns into thrombin. It activates the platelet. I'll show you what that is here in a second. And activating it starts something called adhesion. So what adhesion is going to do is going to activate the platelet to start sticking in and around the area that's broken. It's going to start sticking to the blood vessel wall itself and start trying to build up from there. Then it's going to cause it to aggregate. And that aggregation is platelet to platelet. That's where the platelets come together. Now, when we talk about aspirin, what aspirin does, it's an anti-aggregate. That means that it will not allow the platelets to stick together to help form a clot. That's what's very important in taking the aspirin when you have an acute MI. And then you get the fibrinogen to form the fibrin when it gets activated, and it helps do the plug formation. All right, now we talked about it, here's how it works. When platelets, again, they're nice and spherical. They move through the blood system with ease, no problem. They don't stick anywhere. But when they get activated, they turn into this nasty monster. They get all these things that stick out. These stick out and they actually grab stuff. So, when they come by, as they get closer to the quote unquote leak or the rupture in the blood vessel, it's activated, and then it opens up like this, and it starts grabbing hold of the tissue, the busted area of the actual blood vessel, and it starts grabbing other platelets. So here's the process. You've got an injury or damage that occurs. Remember, the neuro kicks in. It'll constrict it down to limit flow, not stop flow, but to limit the flow. The platelets get activated, so they'll start sticking in and around the area, and then they start clumping together. They start aggregating, and then they'll release some clotting factors, fibrin and fibrinogen, and then it's grabbing also red blood cells that's coming by, and it's putting them in this clot. And then you get the fibrin. The fibrin is literally just a protein that starts building a web over top of this. So really, to put it like in some sort of understanding, what happens is you kind of like have a rupture in the dam, or you have a break somewhere in, like, say, a wall or whatever. The platelets act as mortar. If you're going to use like bricks or the blocks, it acts as a mortar. So it builds a foundation. The red blood cells act as bricks or the blocks itself. It's just grabbing something to hold it in there and shove in there, so it'll grab and hold and build this wall. So you've got the platelets acting as a mortar. Then they start using the red blood cells as bricks themselves to build in and pushing this all together and make this and build this up. With that being said, that the fibrinogen that gets turned into the fibrin starts making this web-like structure over top of it. So then you have like literally this mesh, this netting that comes over and holds it all together. And believe it or not, it's a pretty good process when it works. So with that being said, now we can start getting into kind of the nuts and bolts of other things that help out to make blood cells. We're going to talk about bone marrow, the liver, and the spleen. Bone marrow is quite simple. We've talked about this before when we talked about immunology, when white blood cells are formed. Again, the bone marrow is responsible for kicking out a stem cell, and depending on what the needs are of the body, the stem cell will get activated to either turn into a specific type of white blood cell, red blood cell, or a platelet. That's it. That's all it does. The bone marrow makes the stem cell, it kicks it out, and then depending on the body's needs and also hormone release, it'll tell it what to make out of that stem cell. Pretty cool stuff. The liver. The liver does a lot of things. It is a huge, big, bad dog in our body in achieving homeostasis. But one of the things that the liver does, as far as clotting, is it actually makes the fibrinogen and these factors, 2, 5, 7, 9, 10, and 11, and 12. It makes those factors. And again, that's all part of the clotting cascade. The spleen. The spleen is pretty unique. The spleen in itself, it actually kind of stores blood. I know that sounds really weird, but it'll store about 1 liter of blood. That's something you really don't put on here, but it'll store like 1 liter of blood. That's important in shock trauma. When you start losing blood somewhere, if the bleed is big enough, the spleen will kick all that extra blood out there just to try to keep oxygen and CO2 circulating around, in hopes that you form a clot fast enough to be able to do that. They'll also recycle out old, remember apoptosis, when the red blood cell breaks open, and it'll actually kind of store the red blood cells, and it'll kind of recycle out the pieces and send it to the liver to help to store what's needed, like the hemoglobin and stuff like that. Your body actually tries to recycle all that stuff, because that way you don't have to try to make new. So it kind of uses the old proteins and reuse them if possible. Also, platelets and white blood cells are stored in there. Just in case of infection. It also helps try to help with immunology. It tries to help with the infection and rid yourself of any viruses or pathogens. The spleen, location. It's kind of right next to the stomach. Kind of sits right up on top of the stomach. In shock trauma, which I know we haven't done yet, it's really important because if you think about it, that's on the left side. People drive and sit on the left side. If you're T-boned in a wreck, the spleen is not just a nice, thick, hardy organ, kind of like the liver, or a hollow organ like your intestines or stomach. It's kind of like a pulpy, paperish mesh. It's really delicate. That's why it's up in here, or it's believed to be up in here and protected by the rib cage. The problem is that if you can actually fracture your spleen. So if you take a T-bone or a side impact on that side and you damage the spleen, you can actually rupture the spleen. And that's a big deal, because remember I said it's about 1 liter of blood that's stored in there, so you'll have that blood loss right quick. Again, they can remove the spleen. You can live without the spleen, but also you tend to get sicker, because remember, it also houses the white blood cells to help fight infection. And it's also it kind of helps filtrate too some of the infection as it comes through there through blood flow. So it's pretty big deal. It doesn't really get a lot of credit for what it does, but it's a very needed organ. You can live without it, but you kind of don't want to. I do know people that have what's called the splenectomy, which is the removal of the spleen because of trauma, and the fact that it's just so pulpy and can break and get fractured very easily and cause severe hemorrhaging, internal hemorrhaging. It's a big deal. This is kind of like a crosscut of the spleen. What they have is a capsule, which is the actual outside of it. You have these tuberculose that kind of helps give it the structure because, like I said, it's pulpy, it's mushy, and it's pulpy. So that kind of just gives it some sort of form. You've got the white pulp, which technically is referred to as like where the white blood cells are stored inside there, because again, it really is more of an immunologic function. It actually does a lot of fighting viruses and bacteria and stuff like that. And in this is called red pulp. And that red pulp, a lot of the red blood cells are stored. So if needed to be activated, they can get sent out. All right, so let's talk about blood types. Everybody seems to know their blood type. A, B, B, O. And let's talk about transfusion reaction. We talked about this before. We're going to just kind of touch on it really briefly again because it's very, very important. So here you go. They call them group A's, group B, whatever. But remember, you're back to your immunology. You've got cell markers on the outside of the cell. Red blood cells are no different. They just happen to have a certain cell marker. That's either A, B, AB, or they have no markers, which is called O, type O. So with that being said, you can go ahead and they've got the antigen B. They've got that out there. That's in the blood flow, and they have these antibodies for B if you're type A. So if you were to give, and the same thing goes true for B. So if you were to give one of these to one of the others, A or B to a B or an A, if you go ahead and accidentally don't blood type them correctly and give it wrong, you can have something called a transfusion reaction. And believe it or not, it takes less than a drop of blood to cause a chain reaction that will kill a person almost instantly. That's why they're very, very, very cautious when they type out blood. So remember, you've got the antigen in there on top of it and the antibody for the other. So if this one's introduced into the bloodstream of this one, this antibody is going to attack and kill and then cause a transfusion reaction. Same here. AB is unique. AB has no antibodies whatsoever. AB is known as the universal recipient. That means it can get A, B, or O because it has no antibodies. So therefore, it'll come in and you can introduce either A, B, or O, and it has no antibodies, so it's not going to attack. So it's pretty neat. Type O is the universal donor. Now remember, the antibodies are in the plasma. So if you give packed red blood cells, and it's just O is called the universal donor. You can give this to anybody as long as you get rid of the antibodies that are in there because it's got the A and B in there. So it can't take any of these. Type O is very specific. It can't take any of these bloods, but it can be donated just as packed red blood cells as long as the antibodies are out of there, out of the plasma. You just give the packed red blood cells, which is just red blood cells, nothing else. You can give those packed in. They can go to any of these because it doesn't matter about the antibodies, or not so much the antibodies, but it doesn't really matter. And it can go out there. And even if you do get a little bit of antibodies, it's not going to matter. But really, this is the group, or type O is the universal donor, and A is the universal recipient. So I know that's a little confusing. I don't know any other way to basically explain it. That's why one of the reasons why I did immunology first, because it's very important that you knew what the antibodies are built in there for. So again, universal donor can take any of these bloods because it doesn't have any antibodies. So if you give the blood over to this one person who has AB blood, they can take it all. They're called the universal recipient. This is the universal donor. This person can go ahead and donate blood and give out to anybody because it doesn't really matter. Because even if it does have the plasma, I'm sorry, I didn't even think about that. Even if it does have the plasma, it doesn't matter. There's no antibodies here, and they have the A and B in there. So it doesn't matter. This can go to all these people. All right, let's talk about something called sickle cell disease. Sickle cell disease is a genetic defect in the hemoglobin, not the cell itself, but the hemoglobin, and it affects the way the blood cell is shaped. And what happens is it makes it look like a sickle. It's not the nice rounded shape. It's kind of caved in and like that, and it looks like a sickle. Now, mind you, that's going to cause problems because it's not the nice little, like we said, an inner tube or where you can float on down the river and it'll actually get caught. So you're going to have crises all the time. Also, the fact that they're no longer nice and rounded out shape, they're hemolytic. The hemolysis for sickle cell is great. I'm going to explain that here in a second. Here's a kind of a picture of it. This is normal red blood cells. This is, you will have normal red blood cells, but you also have this sickle celling trait. So these are what gets stuck and caught up. Real quick, if you do have sickle cell disease, one of the ways that they do this and why the blood transfusion, knowing universal donor, universal recipient, and blood types is important, because believe it or not, what they'll do is they will take blood out of a sickle cell person. They'll basically just take it. They'll go ahead and they'll give a unit of blood off, or they'll take a couple units, and then they'll give them back blood and transfuse them with new blood. The idea is to get rid of some of these sickled cells out of there and give them nice new normal red blood cells. Even though they did not genetically make them with their own bone marrow, it's still, they have them, and they're good for up to 6 months. So there's some things we're going to talk about. One of the things you do need to know is called vaso-occlusive crisis. That's going to be in your arteries or your veins. Basically, I've got a picture of that. I'll show you that here in a minute. Acute chest syndrome has to do with a vaso-occlusive crisis in the pulmonary capillaries or the pulmonary arteries and veins. You also have something called splenic sequestration crisis. Basically, it's when the sickle cells remember we talked about the spleen and how it houses red blood cells. It actually can get caught up in there and cause it a crisis. So here we go. I'm going to show you what it is. It's a bad slide. I'm sorry. It's the only picture I really could find that's really good. So remember, we talked about normal blood cells. Normal. They flow through. They can go through. And as the arteries start going into arterioles and capillary beds, they start getting smaller and smaller and smaller. These just bump around, and remember, the capillaries are big enough to allow one red blood cell, single file, to pass through. With this being a sickle cell shape, that's going to be even worse. Because now what happens is, it can actually get, if you have a whole bunch of them put together, they'll actually get caught and clump in an area. Remember, if you block anywhere, you start causing ischemia, which is lack of oxygenation down the road. So anywhere you block it can happen. So remember we talked about ischemic strokes? You can have ischemia due to sickle cell crisis. Depending on where it's blocking is depending on where they're going to feel the most pain. And let me tell you that this is very, very, very painful. It is an acute crisis. They can actually have this back up and start having engorgement in the areas behind. Because imagine if this got blocked up across the whole entire way. So now you're going to start these red blood cells, the heart's still pumping, still sending blood to this area. Now it's going to start backing up. And if it backs up in and around an area, it'll start having engorgement. We'll talk about the life-threatenings. These are other complications. Really not going to go into these, but they're there. So, let's see. So one of the things that happens, like I said, those vaso-occlusive crises, it just depends on the area of where they're at. One of the things that these are a sickling of the cell is prone to do, it's not nice and round. So it can't bump and just take a hit like these can. Just bumps and keeps going down blood down the arteries, and it doesn't keep going on downstream. So what happens is these actually rupture a lot easier. They don't last the 6 months. They rupture a lot easier. With that being said, then, you have the hemolysis of those sickled cells. You're left with the normal cells, but your body didn't really pay attention to like, oh, is it sickled or not? I don't care. I'm making blood cells. Oh, well, it got sickled. Too bad. So then you have to start something called anemia. Anemia is where you don't have enough red blood cells to carry the oxygen around in the bloodstream to all the organs and tissues necessary. So you start having something called anemia. It's defined as red blood cells level that is lower than what is normal. You can have an iron deficiency because iron is the big, huge bad dog, or the element that helps make the hemoglobin. So you can have the iron deficiency, which causes anemia. But in the sickle cell world, it has to do with the hemolytic properties, where you have apoptosis, where the cell is just destroyed. Depending on where it's caught at, one of the big ones that usually winds up happening is that most people are sexually active. Well, in males, it winds up causing a priapism. A priapism is an erection that is long-standing. So you have these sickle cells go into a very vascular area. Obviously, when we become sexually active and sexually excited, blood flow is increased. Excuse me, Corona, to that area. But then you have the engorgement of the blood. Now they're sickled, and as you start having it, that gets trapped in that around that area, and then blood can't be released or can't go back to normal flow. So on the flip side of this, remember we talked about the clotting cascade. The clotting cascade are all the factors that you need to be able to form a clot. Thrombophilia or hemophilia is basically where you cannot form a clot. Something is wrong. And typically what's wrong is you are genetically predispositioned to not be able to form clots. You actually don't make a clotting factor. The liver doesn't make it, or wherever else it's made in the body, you don't have a clotting factor made. So imagine in that cascade as you're going down, this gets activated to that, this gets activated to this, then this will activate that. Well, imagine if one was gone. Now you can't clot whatsoever, because in the cascade, you need to go from one to the other, to the next, 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 done. If you take one of those away, you no longer can form a clot. Typically, these people or these patients will know this, and they'll tell you, hey, I've got hemophilia, meaning I can't make a clot. I don't make factor 9, or I don't make factor 10. And it all depends on where it is in the stages where it won't allow clot to form. So typically these patients will get cut. You'll have to do some sort of makeshift tourniquet on them to stop blood flow altogether. And then you'll have to take them to a hospital, and it might be a specific hospital that they go to that has these clotting factors, that has their records, that knows them as a patient, because this happens not all the time, but they do get cut. And you'll find that hemophiliacs really try to avoid getting their head bumped, or falling, getting knocked around, because any disruption, any trauma, any little minor bump can cause a huge major bleed. So they know this, and they try to tell you this, and in the event that they have this, then you basically need to stop the bleeding, put a tourniquet, something to stop the bleeding, and then take them to the appropriate care center. These are some of the you can have the fact that they actually had recent surgery and other things like that. Impaired mobility, if they don't move around a lot, their blood does kind of become stagnant in certain areas and kind of builds up clots, because it's just there, and the clotting factors are all just kind of lumped together, but they're not moving, so they're stagnated, so they just start forming clots and doing the cascade right there and then. So I will tell you right now, for pulmonary embolism, if it's a thrombus, one of the things is that people have been stagnated sitting in the same position kind of for hours on end. So one of the things that they like to use is that people that have been on long car trips and they're having difficulty breathing, and all of a sudden now they're just an acute onset of difficulty breathing, and they have no other risk factors for difficulty in breathing, like they don't smoke, nothing like that. All of a sudden they got difficulty breathing. That might be a PE, or they're on an airplane for 16 hours. Something like that, and that's usually when they have a PE, just FYI. We're going to kind of talk about that already. They kind of have 3 categories, and they call them A, B, and C. I'm not going to gig you on this. I'm not going to make you do matching or anything like this, but just know that they're out there. Again, they're worried about just, even if they get their head bumped or something like that, they're worried about an intracranial bleed. They do have to go to transfusion. They can do transfusions as well. They'll also have, they'll remove a unit or 2 of blood that doesn't have any of the clotting factors and get new blood that does have clotting factors in it. One more thing, and I think that's going to be it for this part of our lecture. Something called DIC, which is disseminated intravascular coagulation. This is kind of on the flip side. Basically, this has to do with making of clots. Really, truly, this is a condition. It's a medical condition, but you can have it or be diagnosed with this when you start losing your clotting factors. What happens is that basically you use up all your clotting factors and your platelets, and your body has to make those. Remember, your bone marrow make the platelets, your liver is making clotting factors. So what happens is you use these or burn through all this, because it's not an infinite resource. It is finite. There is only so much that you have. and then you use them up, and therefore when you have some sort of insult or injury somewhere else, you cannot make a clot. Therefore it causes bleeding that cannot be controlled. Really where this comes into play, like I said, this is a medical condition. You can have it. I don't know too much more about this, but where you're really worried about this is going to be in trauma, especially multi-system trauma. I know we haven't talked about shock trauma, but if you are in a bad car wreck and you're beat up and banged up and broken bones and head injury, and you've got multi-system, like a whole bunch of stuff is bleeding and tore up, where you'll see that is in the multi-system shock patient, because your body's trying to go ahead and control all this bleeding in your body, on its own, and it can't, because it'll have major bleeds everywhere. So it's trying to clot everywhere, and it's just not enough. So without being enough, it just can't form a good clot, and it may have some of it started and it's kind of there, but it's loosely held together, and then you jar the patient and you knock that clot free. Well, now they're actively bleeding again. That's why minimizing multi-system trauma patients is so essential, because if they're bleeding everywhere and they're trying to form clots everywhere, and they burn through their resources, their clotting factors or their platelets or both, they won't be able to clot. Then you have uncontrolled bleeding, especially when it's internal. There's nothing you can do about that. You can't cut the patient open to stop that bleeding. They need to be taken to a trauma center right away, or a surgical center, to be able to have that done. But again, this is also a medical condition. People actually have this as a medical condition, that they form clots all the time, and then they wind up using their clotting factors, and then they don't have enough to stop bleeding somewhere else. So let's talk about your scenario. Scene safety. If they have it, if they're having a vaso-occlusive crisis, which is usually called the sickle cell crisis, they'll tell you, hey, I've got sickle cell. And then you'll go from there. One of the things that I'm going to tell you, and I'm not trying to make this be racial, but typically sickle cell crisis is an African-American oriented disease. I don't know why that is. It's not that other nationalities can't have it. They do. It just seems to primarily surface in the African-American community. So be very conscientious of that. Monitor. If they have hemophilia, you need to try to see if you can stop the blood loss, especially if it's external bleeding, like they've got a cut or something of that nature, and you need to go ahead and put on a tourniquet, control the bleeding. History taking, again, that's probably where you're going to find out that they more than likely do have some sort of medical condition, whether it be the hemophilia or the sickle cell trait or the sickle cell disease, and they're in crisis. Again, like there's some of the questions, have you had a crisis before? When was the last time you had crisis? Because that might be important. Like I said, they get transfused. If you have sickle cell or even hemophilia, they'll get transfused, and the sickle cell, they're trying to put in fresh new red blood cells that aren't sickled. And in hemophilia, they're looking to put in the clotting factors themselves. And I believe they actually can do the clotting factors in and of themselves. So they might just need to have the clotting factors put back in if they're hemophiliacs. Do your secondary assessment. Just monitor, make sure there's no changes, make sure what you've done is working. If the tourniquet's in place, fantastic. One of the things that's for sickle cell patients is they're in a lot of pain. It's very, very, very painful. So you may have a paramedic partner that will give them analgesics, basically pain control, because it does hurt quite a bit. One of the things they do talk about trying to do, if there is no signs of bleeding in sickle cell patients, is to vasodilate them using nitro. That can happen as well, but usually morphine will usually take care of that. Again, reassess. Make sure your interventions are working. Emergency care, you can do oxygen fluids, pharmacology, again, if you're for ALS. Comfort, position of comfort, it's very important. Try to get them to rest. Psychological support is very important. Reassure them, tell them like, yeah, hey, look, we're doing the best we can. We're going to do what we can for you. Yeah, and they more than likely, unless they're children, this is not their first rodeo. They know. Be optimistic and honest with the patient. That's really all you really need to be. Like, hey, I'm going to do the best I can for you. We're going to try to stop this bleeding. If they're hemophiliacs, sickle cell, yeah, hey, listen, I know, time is muscle with the sickle cell, because if they got any ischemia, it can turn into infarction, which will lead to dead tissue. So that's not good. And there's a little funny tidbit for you. Any questions, let me know. I will work on the endocrine presentation tomorrow, and I will try to have that up for you. I'll talk to y'all later.